Hi guys, welcome to our lesson on pediatric medical emergencies. We're going to be diving into a number of specific medical emergencies faced by the pediatric patient. Let's go ahead and get started. We know that a variety of pediatric medical problems can activate the EMS system. The majority of those typically involve the respiratory system or some type of shock-related issue. There are a number of other medical conditions that you can see. They're all rather rare, just as a pediatric patient is. We have to remember that since we don't see pediatric patients regularly, that we must be able to focus in on their individual needs. Remember, pediatric patients are not just small adults. There's a number of other body systems that can be involved that can lead to a medical emergency for a pediatric patient. One of those primary ones that we think of is infections. Infectious diseases may be caused by the infection or an infestation of the body by some type of infectious agent. These can be anything from bacteria, viruses, fungi, or even parasites. Most infections are self-limiting, meaning that they're going to take care of themselves over a period of time, but some infections, things like meningitis, pneumonia, or sepsis, can truly be life-threatening to the pediatric patient. Most of the time, you're going to see those core components dealing with respiratory or shock-like symptoms. There are a number of signs of infection that we must be aware of and be looking for on our pediatric patient to ensure that we're assessing them to the full requirement that they need. These include things like fever or chills, tachycardia. We know that pediatric patients are oftentimes tachycardic normally based on their physiological needs, but if we're seeing excessive tachycardia for a pediatric patient, that can oftentimes be a sign of dehydration or infection. Things like a cough, sore throat, nasal congestion all can lead to issues with getting oxygen into your patient. Remember that younger children, our newborns, and our infants are obligated nose breathers. They're going to be breathing through their nose, and so nasal congestion can really lead to a lot of respiratory distress. We also know things like malaise, tachypnea, cool or clammy skin, all can be signs again of infection. Petechiae or red-like purpley rashes on the body are oftentimes a sign of infection, typically viral infection. And then obviously we can see signs of respiratory distress. We'll define this a little bit later on, but remember any symptoms of respiratory distress or fatigue or nasal flaring, any signs of respiratory compromise is considered respiratory distress in a ped, unlike that of an adult. We also sometimes will know that we'll get things like poor appetite, vomiting, diarrhea, all of which can lead to dehydration. Dehydration is a major concern in the pediatric patient as they need that fluid in order to be able to have adequate perfusion throughout their body. We also know that things like seizures or purpura, I can never say that, which is another example of a rash or purple-like blotches of the skin. Again, seizures, headaches, irritability, stiff neck, and bulging fontanelles can also be a sign of an infection. The stiff neck and bulging fontanelles are going to be more along the lines of a neurological infection, things like meningitis or an infection of the meninges, the protective structures and covering of the brain and spinal cord. Now, when we deal with any type of infectious agent, whether it be COVID or whether it be meningitis or even just pneumonia, we should take standard precautions to protect ourselves and minimize the risk of spreading that disease. We also want to become familiar with the common pediatric infections that are going to be encountered in your area. We know that things like ear infections, sinus infections, potentially croup, epiglottitis, meningitis, some of those are going to be more of the common ones that you can see. There are other issues that we have thought that were at one point in time eradicated from our society. These include things like whooping cough or pertussis. Those are no longer the case as vaccinations have become an issue of topic for debate. Since they're no longer vaccinated against those at one point in time eradicated diseases are now coming back and affecting pediatric patients on a more regular basis than ever before. When we think about respiratory illness, we have to recognize that, again, the most common reason why EMS is summoned is because a pediatric patient is either having some type of respiratory distress or leading to respiratory failure, and we'll need to define those individually. Remember, if it's severe enough, it will lead to failure. Any signs of respiratory compromise is defined as distress. Any signs of respiratory rate or tidal volume components now is leading to respiratory failure. And remember that pediatric patients will compensate, crash. and we have to recognize that they don't have a very large reserve for oxygen capacity. When you approach your child with a respiratory emergency, you're going to need to, your care and actions are really going to depend on the severity of the respiratory compromise. Remember, the more severe, the less time you have available to try to stabilize that child before they potentially can crash. We'll also reference again that pediatric assessment triangle, doing the view from across the room and then the hands-on assessment as well to ensure that your patient is adequately breathing, has good skin color and condition, things of that nature. Now we look at the three components of severity of compromise, and we talked about this a little bit, but let's dive a little bit deeper. These three categories include respiratory distress, which is the mildest form of respiratory impairment, respiratory failure, where now we're looking at a problem with either rate, tidal volume, or both in the pediatric patient, and then respiratory arrest, where now we're having the inability to fully ventilate that child on their own. It's important to learn these to recognize these phases in your patient. So we're actually going to watch a couple of videos to let you get an example of that, and then we'll discuss them afterwards. Let's go get started. First is respiratory distress. Mildest form of respiratory impairment is defined as respiratory distress. Things like increased work and breathing, increased respiratory rate. Oftentimes we're going to estimate these initially, but it's very important that you accurately assess this in the pediatric patient. You can probably get away with an estimate in an adult, but in a pediatric patient, we really need to have solid numbers to be able to complete our assessment and determine if this is distress, failure, or arrest. Again, when we're measuring someone's respiratory status, especially in a pediatric patient, it should be measured for at least 30 seconds to ensure that we have a good understanding of their respiratory distress level. It's also better, if you can, to assess for at least 1 full minute. It'll give you a better understanding, but minimally for 30 seconds in the distressed patient. Signs and symptoms of respiratory distress, these include things like a normal mental status that begins to deteriorate, or we start to notice irritability or anxiety in the child, tachypnea, muscle retractions, either subcostal or intercostal retractions, any of those components, nasal flaring in infants, poor muscle tone, tachycardia, head bobbing, where the kid is having a hard time kind of keeping themselves awake, grunting, as they're trying to forcefully exhale as they breathe. It's very common in asthma patients, and then cyanosis that improves with supplemental oxygen. Those are all going to be signs of respiratory distress. Let's take a look at a child who is suffering from respiratory distress, where we can see that.
Your wrong leg.
Get ready first.
You can clearly see the intercostal, subcostal, suprasternal retractions, subclavicular retractions in this child. This kid is really struggling to breathe. Let's watch one more time.
Your wrong leg.
Get ready first.
Here again you can notice the muscles that are pulling against the chest. Again you can see where they're sucking down into the clavicles, around the neck, and then you're noticing that seesaw. The belly goes out, chest goes in, belly goes out, chest goes in. There's different components. This is a very significant amount of respiratory distress. Truly, I would argue this is verging on the point of respiratory failure. Let's take a look at an infant as well. Again, this is a 3-month-old, 25 days old with onset of pneumonia.
So you're getting about 90 breaths, and so now he has a VSD and an ASD.
The metronome is set at 92 beats per minute, so you can clearly see this child is really having some significant breathing problems.
No fever, though, you said, right? But he's been coughing and he had a period of apnea, is that right? He just stopped breathing on Monday?
Yes.
And someone had to blow in his face, is that right?
He got choked, he get choked off of that, whatever he's coughing.
Okay. But he's only had like, what, 2 ounces today, you said?
That's all.
Yeah.
When he started coughing, he turned blue.
the subcostal retractions. Pulse ox originally in the ER was in the mid-80s. Again, we've seen that marked improvement with oxygen delivery. That's how we're again classifying this as respiratory distress. Again, there's that abdominal breathing, that belly breathing. The belly comes up as the chest goes in. Again, in this circumstance, it's extremely important when we think about our patient assessment to complete the ABCDE approach. Airway, breathing, circulation, disability, which will be your assessments, and then your other components of exposure. So the exposure is critical in a pediatric patient. You have to be able to expose their chest to look for those signs of distress. Otherwise, we may easily miss those things if the child is in a onesie or wrapped up in a blanket or just clothed in any nature. Again, it's extremely important for us to recognize that because kids will not last long when it comes to their respiratory distress before progressing into respiratory failure. As we look at respiratory failure, we know that it occurs when the respiratory system is not able to meet the demands of the body for oxygen intake and carbon dioxide removal. Air must go in, air must come out, and blood must go round and round. We know that respiratory failure occurs when the respiratory system is unable to meet the demands of the body in oxygen intake and carbon dioxide removal. This is characterized by inadequate ventilation and oxygenation. Signs and symptoms for respiratory failure include inability, irritability or anxiety, deteriorating into a very lethargic-like state, marked tachypnea that later progresses into a slower breathing rate or bradypnea, marked retractions that eventually again will deteriorate into more of agonal-like respirations, loss of muscle tone, marked tachycardia, later deteriorating into bradycardia, and then central cyanosis that's unimproved with the administration of oxygen. Respiratory arrest is the end result of respiratory impairment. Remember what we've said before, no airway, no patient. Respiratory distress, respiratory failure leads to respiratory arrest, leads to cardiac arrest, and that's what we're trying to hold off. So we have to recognize that we have to be aggressive when it comes to dealing with these patients. We know that as soon as they cease to breathe, it typically is followed by a period of slowing in respirations, followed by agonal respirations, and then into a period of apnea. At that point, hypoxia becomes a significant underlying issue, leading to cardiovascular collapse. The patient begins to brady down, and eventually they'll end up into a PEA or cardiac arrest. Those are the concerns that we have. And if we're not aggressive in our understanding and recognition of respiratory distress, failure, and arrest, it's going to be very hard for us to improve the patient outcome. Again, signs and symptoms of respiratory distress include an unresponsive deteriorating into a coma, bradypnea deteriorating into apnea, absent chest wall motion, bradycardia deteriorating into asystole, and then profound cyanosis. It's pretty rare for a child to be into a lethal rhythm, cardiac rhythm like VTAC or VFib. Typically they're going to go right from issue with respiratory problems right into asystole. They kind of skip some of those more survivable like arrhythmias that we typically see in adults. Management of respiratory compromise, again, the goal really should be based on the severity of the problem. The management should be primarily focused on increasing ventilation and increasing oxygenation. Be aggressive with your airway management. It'll definitely help your patient. We also know that for airway components, we want to make sure we have a patent, well-established airway. We also need to assure continued maintenance of that airway. So when it's necessary, we may need to place an endotracheal tube or other airway adjuncts to support that airway. Breathing is also extremely important. We must remember to administer high flow oxygen, high concentrated oxygen to these patients early on. Again, they don't have a restore or reserve of oxygen like you would see in an adult. And if there's no improvement, the patient should be treated more aggressively. Remember, be aggressive when it comes to pediatric airway management and breathing. Treatment for late respiratory failure or arrest primarily is going to focus around mechanical ventilation with some type of bag valve mask-like device. We know that we're going to need to place an endotracheal tube to ensure a secure and patent airway. We also need to be aware that gastric decompression may be something necessary, especially if bag valve mask ventilations continued for a period of time without an advanced airway. Most of the time we're going to see the abdominal cavity become distended or the stomach to become distended because of buildup of air, which leads to compression of the diaphragm, making it harder for that child to get a full breath in essence decreasing their volume because of the volume of air inside their stomach. That's where that decompression comes into place. We may also have to consider a needle chest decompression for patients who are suffering from some type of pneumothorax. And again, if necessary, even though it's a very late, aggressive procedure, consider cricothyrotomy as an alternative if, again, we have some type of severe upper airway constriction, a foreign body obstruction, something in regards to the upper airway. For circulation, you should obtain venous access. There are times where we will say establishing IV may not be helpful. For example, in epiglottitis, establishing an IV may make the child cry, causing inflammation to rapidly develop in their epiglottis and occlude their airway. But most of the time, it's necessary for us to establish IV access, especially in someone who's suffering from some form of respiratory compromise. Again, we want to transport to an appropriate pediatric capable facility or to a closest local facility if the child is unstable. Always reassess the child, continuously reassess the child, as you're going to be looking for constant improvements or deterioration. Remember, the goal is to determine, are they trending in a positive direction or are they trending in a negative direction? And remember, provide emotional and psychological support. It can be very stressful for not only the patient, but also the parent or caregiver. For upper airway distress, now if we're diving into more specific respiratory emergencies, these include things like croup, epiglottitis, bacterial tracheitis, and foreign body aspiration. Let's go into each one of these a little bit further. With croup is a viral infection of the upper airway. It occurs in children from 6 months to 4 years of age, and it can happen a little bit older than that, but generally their airways become large enough where a little bit of edema won't lead to the croup-like symptoms we're used to, that classic seal bark-like cough. In croup, we know that the viral infection leads to edema beneath the glottis and the larynx. So it's below the glottic opening and it's below the larynx. That's what leads to that brassy, seal-like bark cough that we're used to. Our assessment should reveal that the child would have a mild cold or some other infection, again, most likely viral. They're going to develop this loud, brassy cough primarily at night, and you should never examine the oral pharynx in these children because it's very difficult to distinguish between croup, which is a mild concern, and epiglottitis, which is a really life-altering medical emergency. Management includes placing the patient in a position of comfort, providing some type of cool, mist oxygen, and you may be asking yourself, well, how do you do that? Taking a saline or sterile water and nebulizing it can provide oxygen while some aerosolized mist or well-saturated like aerosolized fluid is going to make a big difference in your patient as far as reducing some of that brassy cough and allowing for some moistening of that inflamed tissue. We also want to be able to consider the administration of racemic epi or albuterol that may be considered. Racemic epi is going to have a much larger effect on the inflammation than albuterol will. Albuterol primarily works more as a lower respiratory problem. Even though croup is technically just below the larynx, which is beginning to define the lower airway, it still presents primarily as an upper airway concern. Here's an example of what that croup would look like in regards to that cough. Let's take a look. As you can see from that video, there's a big concern about that brassy sound, and you can see that the child is having an increased work of breathing. This is a classic sign of respiratory distress, potentially progressing to respiratory failure. And again, it's very difficult to determine if croup is croup or epiglottitis. Then we can notice some slight nasal flaring, some pursed lips, and again, probably some retractions if we were to be able to expose the child's clothing. Now let's look at epiglottitis. Epiglottitis is an acute inflammation of the epiglottis. It's generally caused by a bacterial infection, which would be a form of influenza type B. Typically, it likes to strike children between the ages of 3 and 7 years old. It's a little bit older. Younger kids are more likely to get croup, as older kids are more likely to get epiglottitis. And again, you can actually have epiglottitis even as an adult. The idea here is that we're looking at inflammation of the epiglottis. Here again is our epiglottis. It's what's going to provide the closure for food to be able to travel safely down the posterior portion of the esophagus, and then oxygen to be able to travel down the anterior portion here to down the trachea. When the epiglottis becomes majorly inflamed, it actually occludes both of these openings, and primarily impairing ability for oxygen to be able to travel down through the larynx and get into the lower airways. That's what makes this such a large concern. We also know that because this is a bacterial issue, it's very easy for it to respond quickly to irritation. So we must be aware that we don't want to irritate these children, or we can truly lead to an occluded airway. Your assessment, we're going to find that the child typically will awaken with a high temperature and a brassy-like cough. Again, that's very similar to what you would see with croup. Again, typically the fever is more of a clue with epiglottitis. They're going to have pain upon swallowing, a sore throat, high fever, shallow breathing, dyspnea. You'll notice an inspiratory stridor, and classic symptom is also drooling. Tripod position, drooling, fever, all those things are going to be classic signs that should point you in the direction of epiglottitis. With epiglottitis, never attempt to look at the airway. By visualizing the airway, we take a risk of stimulating that tissue that's inflamed, which will cause a more drastic inflammation, leading to a complete obstruction of the patient's airway. The patient oftentimes, again, will assume the tripod position and will notice that drooling will be present. Those are the big signs that we're looking for: sore throat, inability to swallow, drooling, fever, and tripod position. Management includes appropriate airway maintenance and oxygen administration. We have to recognize that sometimes less is more in children with epiglottitis. What we don't want to do is provide too aggressive of treatment that may cause a child to get upset or cry. Remember, the larynx is just below the epiglottis. If the child begins to cry, it's going to stimulate that epiglottis, and we're going to have inflammation and potentially an airway obstruction that we can't undo. It's important to keep the child calm and recognize your interventions need to be justified based on the patient presentation and their stability. If the airway becomes obstructed, you're going to need a 2-rescuer ventilation with the BVM is almost always effective. And if it's unable to be able to ventilate it with 2 persons in a bag valve mask, we may need to be more aggressive with either an attempt at a endotracheal tube placement, which will most likely not be successful, or a needle cricothyrotomy in order to establish an airway below the site of inflammation, below the epiglottis. Intubation equipment should be available. Again, it's contraindicated to intubate this child unless an obstruction occurs. We want to do an immediate transport and be very careful to handle the child gently. Do not visualize the airway and try to avoid IV sticks. Do not irritate the child. And again, if you take a look at your book at page 97, you can see how you can actually truly tell the difference more so between croup and epiglottitis. The big difference here is the inability for air to go into the patient. And again, we're noticing that there's a clear obstruction because of the epiglottis and the inflammation. Let's take a look at a endoscope of a swollen epiglottis, just to give you a visualization of what this would look like in a patient. Again, remember, we do not visualize the epiglottis in a case of epiglottitis. This is just for educational purposes. You can easily see how small that airway is. We know that in Peds, their epiglottitis is more omega-shaped, making it much harder for bigger and floppier in general. And then when you add that inflammation, look at the little teeny tiny airway passage you have in this patient. Almost looks like there's an abscess on there. This is what the big concern is. If that were to get irritated anymore, it could swell to the point where it would occlude the airway. Those are all extremely concerning components. Now, the next form that we look at for medical emergencies is bacterial tracheitis. This is a bacterial infection of the airway. Typically, it's a subglottic region, primarily affecting things like the trachea. We know that it afflicts mainly infants and toddlers, again 1 to 5 years old, but and may be followed by an episode of croup. Oftentimes, bacterial tracheitis will turn into croup. Your assessment-wise should reveal the presence of a high-grade fever accompanied by coughing up of pus and/or mucus. Normally, children don't cough up or have a productive cough unless it's some type of severe pneumonia. But bacterial tracheitis is one where they will cough up a significant amount of phlegm or pus. The idea behind that is their airways are much smaller, so a slight infection with mucus production or pustules that are bursting can lead to an obstructed airway, and again, the need for them to work out that obstruction to clear their own airway. We also notice that they're going to have a hoarse voice, and you may notice both an inspiratory and expiratory stridor as part of this. Again, it's a higher level issue. It's an infection, again, bacterial infection of the trachea, or the subglottic region, I should say. Management includes managing the airway and breathing. Again, oxygen is important in these cases, most likely preferred by blow-by, or by having mom, dad, caregiver go ahead and provide oxygenation to the patient by blow-by. Ventilations may also be necessary, and if that's the case, typically it will require higher pressures in order to get adequate amounts of air into the child's lung. This is because of the restrictions in those pustules or in that mucus. Oftentimes in these cases, on your pediatric BVM, you will need to disable your pop-off valve so that you can have those higher pressures than 10 centimeters of water. You may also want to consider the use of intubation in the case of a complete airway obstruction or some type of tracheal-like mucus or pus-like plug. That oftentimes will allow for you to be able to not only work past that, but also to be able to increase the lower pressures within the airways. Foreign body aspiration is another major component that we look at. We know that it's the #1 cause of in-home accidental deaths in children under the age of 6. Typically, it involves food or other objects because we know that children under the age of 6 are exploring things with their senses, primarily through their sense of taste, putting everything in their mouth. The big assessment component we're going to look for is going to be the difference in a partial versus complete obstruction. A partial obstruction can lead to hoarseness, abnormal sounds, stridor-like issues, but the child will still be able to move some volume of air. A complete obstruction, there's no air moving in or out of the child because of the obstruction, and that becomes a major concern. Management for foreign body aspiration includes, for the partial obstruction, make the child as comfortable as possible and then administer some type of humidified oxygen. Have intubation equipment available, including your McGill forceps if necessary, and transport safely to the hospital. If it is a complete, we're going to utilize our basic life support back blows and chest thrusts for young children and infants, and things like the Heimlich maneuver or CPR if the child becomes unresponsive. We also can use the laryngoscope and McGill forceps to visualize the airway to try to potentially remove the actual foreign body obstruction. Now let's take a look at some more specific respiratory emergencies, focusing primarily on lower airway distress. These include things like asthma, bronchiolitis, pneumonia, and then foreign body lower airway obstruction. With asthma, we know asthma is a chronic inflammatory disorder of the lower respiratory tract. The pathophysiology allows for us to characterize it by bronchospasms and excessive mucus production. We know that asthma is a 3-part process, including inflammation, mucus production, and bronchoconstriction. We also have widespread but variable airflow obstructions. These include things like mucus plugs in some of our lower bronchioles or tertiary bronchi. We can also see this with fluid buildup in the case of inflammation, leading to a narrowing of the airway structures themselves, impeding the flow of oxygen into the alveoli for oxygenation and diffusion to occur. We also know that the airways oftentimes will become hyperresponsive to an irritant, leading to the onset of an asthma attack, generally progressing into a more severe form if left untreated. Now, these pathophysiologies are oftentimes triggered by a set event. We refer to them as triggers. These are environmental allergens, cold air, exercise, food, irritants, stress, and even certain medications, like beta blockers, more so in adults. Now, there is a two-phase reaction that happens during an asthma attack. The first is the release of chemical mediators such as histamine. Histamine leads to leaky capillaries, which is going to cause increase in inflammation and an increase in bronchoconstrictions. Right? We know that these bronchoconstrictions can be reversed if we use an appropriate medication. We know that bronchodilators such as beta-2 agonists are going to be what truly has a major effect on reducing those bronchoconstrictions. The secondary component is the inflammation of the bronchioles as the cells of the immune system begin to invade the respiratory tract. This causes an additional level of edema and further decreases respiratory airflow, primarily in the expiratory phase. Remember, with asthma, patients can get air in, but they can't get air out effectively. It's oftentimes where in a pediatric patient you'll see them grunting or exhaling with a audible ugh as they're trying to force out what air they can because of the massive amounts of air trapping that can occur. We also times know that additional edema will cause more problems, and that we know that if the edema and the inflammation or the constriction is significant enough, they may not respond to our bronchodilator medications without it having administered through some form of positive pressure ventilation, either through endotracheal tube with a T-tube nebulizer, or the case of a bag valve mask with a inline nebulizer as well. Your assessment can often be differentiated from other pediatric respiratory emergencies primarily by history. We can look at what medications the patient is on, get a good sample history from family, parents, or caregivers. Will generally lead us into the understanding of what was the trigger for the asthma attack, and then again the patient will have a history of asthma. Now, we also know that we'll generally see the patient sitting up, leaning forward, and breathing at a very fast rate. They'll be tachypnic. Wheezing oftentimes may be heard audibly, and that's a concern. But a bigger concern, an ominous finding, is the lack of wheezing when they're breathing. We should hear lung sounds and sounds of breathing when the patient is attempting to move air. But in the case of a severe asthma attack, oftentimes that airway obstruction, based on the inflammation, the constriction, the mucus production, can actually lead to such air trapping that additional air can't go in, even though the patient's chest wall is moving and they're attempting to get rise and fall to their chest. That is a true medical emergency. Now, when we look at the management for asthma attacks, we know that our first and always primary component is to establish an airway. Remember, no airway, no patient. We also know that the use of supplemental humidified oxygen will be very helpful, and that again should be high concentrated, high flow oxygen. From there, we're going to move into our pharmacological interventions. These include things like a beta agonist of albuterol, albuterol with a mix of ipratropium to make a dual neb, terbutaline, levobuterol, methylpyranol. All of those can be common medications that you would see for bronchodilators. We also know that we may want to consider the administration of steroids, some solumedrol. This will help our patient not necessarily in the most immediate concern, but over a period of time will help reduce that inflammation. Again, the mucus production and the inflammation along with the bronchospasms are the three things that we're treating. We generally will start off with the dual neb treatment, typically 2.5 milligrams along with 500 micrograms of ipratropium and 3 milliliters of saline. Again, that's administered via updraft nebulizer at 6 to 8 liters, and also can be aerosolized through the process of a bag valve mask or endotracheal tube like we talked about. The goal of that is we use those by using our steroid and by using our dual neb, we're hitting all three factors. The bronchoconstriction, we're using the albuterol component to relax those smooth muscles. The ipratropium is going to help dry up some of those secretions, that mucus production from those goblet cells. And then the third portion is the steroid, which will help reduce that inflammation. Those three components are going to be very important when it comes to helping stabilize your child and avoid the progression from distress and failure to arrest. Now, one of the major concerns we have with an asthma attack is when that asthma attack will not break based off normal pharmacological interventions. So we have to define what that is, that status asthmaticus. It is a severe prolonged asthma attack that cannot be broken by aggressive pharmacological management or medications. The child will have a greatly distended chest because of the significant air trapping and the inability to exhale that air volume out. And the patient will generally look exhausted, severely acidotic, and most of the time dehydrated. In these situations, be aggressive with your airway management and prepare for intubation. Measure your child using the Brousel tape to know what equipment you'll need to use. And be prepared to intubate that child if necessary. Again, intubation with the administration of a beta agonist like Duolneb would make a great difference to them if it gets to the point where we cannot break that asthma attack through inhaled medications alone. The next emergency we look at is bronchiolitis. Bronchiolitis is inflammation or a respiratory infection of the medium-sized airway, generally caused by a respiratory infection, and we would refer to this as a form of RSV, or respiratory syncytial virus. Again, it affects the lining of the bronchioles. Now, this is characterized by a predominant expiratory wheeze and will clinically resemble that of asthma. We oftentimes will think that children who are young enough will be suffering from asthma, when oftentimes truly more of a acute diagnosis of bronchiolitis. Because their airway structures are so small, any inflammation can lead to an obstruction and lead to air trapping and wheezing. We also know that this is rather contagious and spreads easily throughout daycares or preschool-like facilities. Your assessment, the goal is to try to distinguish between an asthma-related emergency and bronchiolitis. Generally, you'll see a low-grade fever that will often exist, showing signs of some type of infection. In this case, that would take us away from our underlying differential diagnosis of an asthma attack. Again, the other major influencing factor is age. Asthma rarely occurs in someone that's less than 1 year of age, but bronchiolitis does. Management includes the administration of humidified oxygen by a blow-by or mask, supportive ventilations when necessary, and making sure that your equipment is ready and available for the individual patient that you're treating. Remember, measure the patient with your Brousel tape to determine what equipment you'll need to use if and when that comes to be. And then also consider some type of bronchodilator by nebulizer. Again, a Duolneb or an albuterol treatment can be very effective in these children. Pneumonia is another component we look at. It is an infection of the lower airways and the lungs and can be both bacterial or viral. Most commonly, it will appear in infants, toddlers, and preschoolers somewhere between the ages of 1 and 5. It can fall outside of that range as well. We know that a lot of times we think about vaccines for a number of the respiratory illnesses that children will face. There is a pneumonia vaccine that is available, but it's really reserved or limited in its use in pediatric patients. Your assessment would reveal a history of a respiratory-like infection, generally a low-grade fever, decreased breath sounds unilaterally or bilaterally, crackles, rhonchi, and then pain in the chest area on inspiration or palpation to the chest. Management, again, is to ensure a patent airway and administer supplemental oxygen, support ventilations as needed, and emotional and psychological support for both the patient and the parents, because oftentimes parents will feel very guilty if they feel that they've caused or are potentially related to the onset of pneumonia in their child. Foreign body airway obstructions on the lower half of the airway is something that we deal with as well. We know that a foreign body can enter the lower airway if it's too small to get caught or lodged in the upper airway. The foreign body can act as a one-way valve and oftentimes will prevent distal lung tissue from properly inflating, properly having that surface area available for oxygenation and diffusion of respiratory gases. It's also considerable and common to see coughing in children as well. They may have diminished breath sounds, and this can also oftentimes lead to positional asphyxia. That's a small object, the child gets laid down flat, it obstructs a larger airway, the child no longer can breathe properly. They sit the child up, the foreign object moves, and now they can breathe again, leading to that example of positional asphyxia. Most of the management of that includes support of the child, including positive pressure ventilation if necessary, but primarily supplemental oxygen, position of comfort to prevent that positional asphyxia, and transport to a pediatric capable hospital. We're now going to switch gears a little bit and talk about the other common aspect of medical emergencies in children, and that is shock. Shock can come in a number of different fashions, as we'll discuss throughout our PALS certification course. These include things like obstructive shock, distributive shock, hypovolemic shock, and a number of others that we'll discuss. Let's first start off with one that's rather common, which is hypoperfusion shock. Hypoperfusion shock is inadequate perfusion to the tissues, which ultimately results in tissue hypoxia and an extreme level of metabolic acidosis. Shock is an unusual occurrence in children. However, it is one of the second most common leading causes of cardiopulmonary arrest in children. Now, the causes have a wide gamut of ranges, including things like hypothermia, dehydration, infection, sepsis, trauma, and blood loss. When we look at the severity of the shock, we have to recognize that children will try to compensate. Remember, kids will compensate, crash. So compensated shock is oftentimes referred to as early shock. The body is able to compensate for the decreased tissue perfusion through various physiological mechanisms. Things like shunting of blood, increase in respiratory rate, increase in cardiac output through increased heart rate. All ways in which they're trying to compensate initially for that early shock. Those signs and symptoms include irritability or anxiety, tachycardia, tachypnea, weak or peripheral pulses or full central pulses, delayed cap refill, more than 2 seconds in children that are less than 6 years of age, cool pale extremities, and a systolic blood pressure within normal limits. And last but not least is a decrease in urinary output. Things like dry diapers, crying with lack of tears, sunken in orbits, or fontanels. Now, when we look at the next level of shock, from early shock or compensated shock, now we look at decompensated shock. This is where the compensatory mechanisms that have been put into place now begin to fail. These include things like heart rate and increase in heart rate, increase in respiratory rate, now begin to fail. And since those compensatory mechanisms fail, we see a drop in the overall blood pressure. These signs and symptoms include things like very lethargic or coma-like patient, marked tachycardia or bradycardia, absence in peripheral pulses or weak central pulses, marked delayed capillary refill, cool, pale, dusky, or mottled-like extremities, that's a sign of circulatory collapse, marked decreased urinary output, again through the form of dry diapers, crying without tears, sunken in fontanels or orbits, and then marked decreased urinary output, hypotension, and then again we talked about the absence of tears. So we've talked about early shock, decompensated shock, and now we have to feel out irreversible shock. Irreversible shock is something where treatment measures are no longer adequate or too late to prevent significant tissue damage or death. This, despite resuscitation efforts, organ death generally will occur. In order to hold off this irreversible level of shock, the best treatment is prevention. That means early recognition and early interventions. Now, if we look at the common signs of hypoperfusion in a child, you can see things like absence of tears when crying, rapid heart rate, rapid respiratory rate, decreased urine output, pale, cool, clammy, or mottled-like skin, weak or absent peripheral pulses, delayed cap refill, and impaired mental status or unresponsiveness. We really must pay close attention to these different types of signs and symptoms of hypoperfusion in the child. Let's now look at the categories of shock that you will be dealing with. Now remember, shock can be classified in a number of different ways. These include things like cardiogenic shock, heart-related issues, pump-related issues, hypovolemic-related shock. This includes things like lack of volume, lack of fluid, lack of blood. Obstructive shock, something that's going to interfere with blood flow. That could be an example of a compression issue, or it could be an example of a pulmonary embolism, and then or even airway obstructions for that matter. And then distributive, where we're dealing with the fluid shift or pull from the vasculature system. These could be things like anaphylaxis or burn-related issues or sepsis. Oftentimes, they're going to be classified into two primary categories of shock, those that are cardiogenic and non-cardiogenic. We know that cardiogenic is the most often fatal for pediatric patients. Now, non-cardiogenic shock, the first is hypovolemic. It results from a loss of intravascular fluids. Their tank is low on fluid. How can they lose their fluids? Well, that can be through excessive diarrhea, excessive urination, things like a DKA. It could be a lack of intake as well. Treatment generally focuses on, believe it or not, airway management first and foremost. We need to maintain and make sure our airway is supporting our patient's needs. We also need to consider IV access and a fluid bolus. For a pediatric patient, a fluid bolus will be 20 mLs per kilogram. Children may oftentimes require multiple fluid boluses in order to allow for a true compensatory mechanism when it comes to non-cardiogenic related shock. That can be anywhere up to 80 to 100 milliliters per kilogram. Now, our state protocols allow for us to repeat that fluid bolus of 20 mLs per kilogram once to give us a total of 40 mLs per kilogram. We want to be very careful not to put our pediatric patient into fluid overload, which can happen very easily in the field. The next form of non-cardiogenic shock we have is distributive shock. In distributive shock, we notice a marked decrease in peripheral vascular resistance. Oftentimes, we see a loss of tone of the vessels, leading to vasodilation and then a drop in pressure and cardiac output. These causes include things like sepsis or septicemia from a bacterial level infection, anaphylactic reaction, or damage to the brain and or spinal cord in the example of neurogenic leg shock. Septic shock generally results in an infection, usually bacterial, that starts locally and spreads to the blood. At that point, the infection then becomes systemic and presents with a number of signs and symptoms, including an ill appearance, altered LOC, tachycardia, delayed cap refill, cool, clammy-like skin, and inability of the child to recognize their parents, right? They have a hard time differentiating between strangers and their actual parents or caregivers. This is typically abnormal for children who are rather young. Management for septic shock includes supplemental oxygen, high flow, aggressive airway management, and intravenous access. Again, we need to consider our fluid bolus therapy of 20 mLs per kilogram, and if necessary, consider initiating a vasopressor therapy such as an epidopamine infusion or epinephrine push, depending on protocols. The next level of shock we have is anaphylactic shock. Anaphylactic shock truly can be a life-threatening experience for a child. It results from an exposure to an antigen which the patient has been previously exposed to, and we see a widespread, massive immune response to it. That immune response causes massive vasodilation and for the capillaries to become very leaky and likely to lose fluid out of the vasculature. Signs and symptoms for anaphylactic shock include tachycardia, tachypnea, wheezing, hives or urticaria, anxiousness, edema, and hypoperfusion. Our management for these folks include really focusing on airway to ensure that we have an adequate airway. Without an airway, again, we have no patient. We also know that we need to establish intravenous access that may be in the form of peripheral vasculature access or interosseous access, depending on the stability of the patient. In decompensated shock, we're going to need to administer epi 1 in 10,000 intravenously, especially if we're seeing failure of the circulatory system. We're seeing collapse in the circulatory system. IM injections of epi 1 in 10,000 are only meant for compensated level shock. We also know that in order to help stop the histamine from having an impact in the body, we need to remove it. So we need to administer an antihistamine, in this case, Benadryl. Compensated shock, again, we're going to try to use our epinephrine 1 in 10,000 IM, just as if it was an EpiPen. But again, the goal of that is to make sure that we have adequate circulation to that distal tissue for it to be able to absorb into the circulatory system and have an impact. Consider a fluid bolus, and again, how much? That's right, folks, 20 mLs per kilogram, and we can repeat that up to 2 times. Now, neurogenic shock is another component we deal with in kids. We know that children are more prone to head and neck injuries because of the size of their giant melon heads. Remember, bowling ball on top of a pencil is a good example of how their neck is very fragile. With neurogenic shock, we see a sudden peripheral vasodilation. This is based on the interruption of the nervous control of the peripheral vascular system. We lose that tone. And so we see CO, carbon dioxide, and blood volume usually are adequate. However, we're going to see a result of that dilation leading to hypovolemia secondary to an increase in reserve volume, the amount of volume that's the container size, if you will, of the vessel. Now, management is going to be primarily focused on stabilizing the injury and giving supplemental oxygen. Remember, aggressive airway management, high flow oxygen is always indicated in pediatric patients. We also know that we're going to need to have a likelihood for peripheral access and that we need to do something to increase that PVR, that peripheral vascular resistance. So we may want to consider the administration of a pressure agent, and the options we have include things like epi, dopamine, and those are the primary two components we would most likely look at. Typically for children, epi is going to be your preferred peripheral vascular resistance increaser to increase that tone. Now, cardiogenic shock, again, we know we have inadequate carbon dioxide. This is going to be, and I know my slides say CO, guys, it really should say CO2. But we know that we have inadequate carbon dioxide. That's going to be secondary to poisoning and or drownings. We oftentimes will see that congenital heart disease will begin to develop and show itself as the child begins to age. And again, the primary cause of heart disease in children is some type of congenital underlying abnormality. Common symptoms of a congenital heart disease is cyanosis. Again, it has to do with the mixing of those arterial and venous blood systems. It's making it very hard for that child to be able to oxygenate all of their blood as it gets perfused out to the remainder of their body. We know that a child with a congenital heart disease may develop respiratory distress initially and then end up with congestive heart failure, or even just suffer from a short cyanotic-like spell. Oftentimes that can be the main issue that we'll recognize initially. We have the tetralogy of Falla is one of the things that we're looking for here. You can see that oftentimes that you're going to have issues with mixing of venous and arterial blood. Here's an example of what we're looking at. You can see that an example, we have a narrowing of the pulmonary valve here, right, making it harder for oxygen to go from the right ventricle into the lungs to oxygenate. You can see that leads to a thickening of the right wall of the ventricle. We also know that it's going to displace the aorta slightly, more so over the ventricular septum, because we know that there's a ventricular septal deficit there, or opening between the left and right ventricle, mixing deoxygenated and oxygenated blood, making it harder for not only oxygen or blood to get to the lungs to become oxygenated, but even harder for the left side of the heart to pump blood out. This is a major concern that we can see. We end up with right ventricular hypertrophy, a weakening of the left side, and a lot of mixing of venous and arterial blood. Now, with congenital heart disease, our goal for management is to administer high flow, high concentrated oxygen, and then ventilate as necessary. Start an IV line, but we're going to run it at TKO. We know that if we were to provide excessive fluid in someone with congenital heart disease, we're more likely to throw them into an acute heart failure or fluid overload, causing significant pulmonary edema. Again, remember, you fill the lungs with fluid, now you have no real estate available for gas exchange, and then respiratory and cardiac compromise. That's not going to be a good outcome for that patient. We are going to go ahead and monitor the EKG because, again, we know we're dealing with a cardiac-related issue to watch for arrhythmias. And if the patient is suffering from that cyanotic spell, we want to place the child in the knee-chest position facing downward. Or for older children, they can actually squat. Believe it or not, those positions aids in the cardiac return, making it easier for oxygenation to happen and for perfusion from the left ventricle up to the aorta to exist. Cardiomyopathy is another component. This is where we see a disease or dysfunction of the cardiac muscle. Oftentimes it's a relation to cardiac heart disease or an infection. It's generally an enlarging or weakening of the heart. It generally is going to be the primary, or will result primarily, I should say, from a mechanical pump failure. One of the big things that you'll see signs and symptoms wise is early fatigue, crackles in the backles of the lungs, jugular vein distension, and engorgement of the liver and areas of peripheral edema. With a pediatric patient, you're more likely to see that liver become enlarged solely because of the backup of blood volume, as it can't effectively push the blood forward because of that weakened cardiac muscle. We also know as far as treatment, supplemental oxygen should always be administered. We should go ahead and give IV access again or obtain it. But then remember, restrict those fluids in these cardiogenic shock patients. We don't want to make the pump fail more, leading to fluid backing up into the lungs. And then we also make sure that we should be treating with other agents as necessary. Your textbook will talk about the use of Lasix. It's really pretty contraindicated in pediatric patients. Other pressure agents like dopamine, dobutamine, epinephrine drips may be utilized in order to help increase the chronotropic and inotropic effects of the heart. Other dysrhythmias that we might see in cardiogenic shock include primarily asystole and or PEA. We very rarely will see a mix of VFib or pulseless ventricular tachycardia. Bradyarrhythmias are the most common, And the dysrhythmia is generally caused by a pump failure, which will lead to cardiogenic shock. And there's a very limited capacity to increase stroke volume when you're dealing with a dysrhythmia. Most of the time, you're going to find that it's going to fall as the heart rate begins to slow and brady down. They'll fall into a PEA or to an asystole. Now, there are a number of tachyarrhythmias that we deal with in pediatric patients as well. For supraventricular tachycardia, for young children or infants, typically a heart rate greater than 220 beats per minute would be of narrow complex rhythm would be an underlying component for SVT. For children, typically anything greater than 180, so over a year of age, 180 beats per minute would also be considered SVT. And then for an adult, we say greater than 150 beats per minute. We know that as the heart is trying to do its components of ka-chunk perfusion, it's not going to be able to do so effectively because we don't have adequate ventricular filling. Without ventricular filling, we get a decrease in stroke volume, which means we get a decrease in cardiac output. Typically, this is a cardiac-related issue and may be secondary to some type of drug interaction. Other things that you may see for signs and symptoms is irritability, poor feeding, jugular vein distension because of the backing up of fluid as it's not having adequate ventricular filling, hepatomegaly, which is in a large liver, and then hypotension as a major concern as the tachyarrhythmia will progress. Now, for VTAC, we've talked about this already, it is very rare in children. Occasionally it's seen in drowning or following prolonged resuscitation attempts as the heart becomes irritated enough that it may produce a VTAC-like rhythm. Signs and symptoms obviously are going to be things like poor feeding, irritability, and a rapid, wide, complex tachycardia. Remember that it's pretty rare for VTAC to happen in children. If we look at the pediatric tachyarrhythmia algorithm, yes, this is a little bit older of an example, but you'll see that the layout is going to be almost identical. I would have you reference your ECC 2015 flip guide for the latest up-to-date information. We can see tachycardia with a pulse and poor perfusion. The primary thing we're going to do is recognize the tachycardia, and then from there we're going to go ahead and assess and support the ABCs as needed, provide oxygen, and place them on the monitor/defibrillator. If after oxygen administration their symptoms persist, we're going to take a look at the QRS complex if it's narrow or wide. If it's narrow and they're unstable, we're going to go down the route of synchronized cardioversion. Your synchronized cardioversion dose is 0.5 to 1 joules per kilogram, and then we can increase to 2 joules per kilogram after that. Generally speaking, start at 1 and then move to 2 for cardioversion. If we're noticing that it's narrow complex, we can also go ahead and consider the use of, and they're stable, after vagal maneuvers, we can go ahead and we can move on into our medications of adenosine or synchronized cardioversion. Adenosine dose should be 0.1 milligrams per kilogram to a max of a first dose of 6 milligrams, and then we can give one additional dose as necessary, typically maxing out that second dose at 12 milligrams most. Again, it should be a weight-based medication. Again, infants rate usually greater than 220, children usually a rate greater than 180 beats per minute. If we're thinking that it's a wide complex, again, we can go ahead and consider the use of amiodarone or other antiarrhythmics such as lidocaine in those examples. And then really focus on what those underlying contributing factors might be by running through your H's and T's. And remember, to secure and verify airway and vascular access, consider expert consultation, and prepare for cardioversion when necessary. Now with bradyarrhythmias, this is probably the most common type of pediatric dysrhythmia that you'll see. Most frequently, it's going to result in hypoxia. Hypoxia leads to inability of the cardiac cells to hold out their normal functions, causing the pacemaker site to slow, leading to a drop in cardiac output, eventually leading to cardiac arrest. Your signs and symptoms is going to be slow, regular, complex, narrow complex rhythm. The child may be very lethargic or experiencing early signs of congestive heart failure, especially with the early onset of bradycardia. Again, this is another a little bit older of an algorithm. Again, reference your ECC flip guide, but it will get us to where we need to. We need to identify and treat the underlying cause. That means maintaining the patient airway and breathing as necessary, providing oxygen, placing the cardiac monitor and appropriate monitoring systems like blood pressure and pulse oximetry, establishing IV or IO access, and 12-lead if needed, but don't delay care if it's a bradycardic rhythm. The first question you ask yourself, is there some type of cardiovascular compromise? If the answer is yes. If the heart rate is less than 60 beats per minute, go ahead and begin CPR. If the answer is no, that they do have strong cardiovascular system, we're going to support their ABCs, provide oxygen, and consider expert consultation. If the bradycardia persists, we can go ahead and administer epi or atropine in order to increase the heart rate. Primarily, you're going to see epi as your main drug that you would use in this case. Again, we're going to use epi 1 in 10,000, 0.01 milligrams per kilogram, or 0.1 milliliters per kilogram. Again, of the epi 1 in 10,000 concentration every 3 to 5 minutes. Atropine, if you're going to consider that for a pediatric patient, that dose is 0.02 milligrams per kilogram. The minimum dose should be 0.1 milligrams, and the maximum single dose should be no more than 0.5 milligrams. And then again, be prepared to consider transcutaneous pacing and treat underlying causes. Now, oftentimes you're going to find there may be a complete absence of a rhythm. This is in the case of asystole. Asystole may be the initial rhythm seen in a cardiopulmonary arrest. Adults typically see VFib before asystole, but children will generally see asystole more common than they will move into VFib. Typically, we're going to follow the pulseless cardiac arrest algorithm per the American Heart Association. And if we need to be worried about ventricular fibrillation or ventricular tachycardia, we know that it's extremely rare in children, but a lot of times it has to do with electrocution or a drug overdose. And then make sure that you follow the appropriate pulseless algorithm for that arrest. For PEA, again, we know it's very common that we're going to see a cardiac rhythm without an associated pulse. Oftentimes these are due to non-cardiogenic causes, and if we can correct the underlying problem, we'll be able to hopefully resolve the PEA. Again, this is where your H's and T's in your ACLS and your PALS manual become important. It's very important that you go through each one of those to make sure that you're effectively on the right pathway when it comes to that treatment. And then again, follow the appropriate algorithm. Here again, you can see another algorithm, very similar for what we would do in a pediatric cardiac arrest. We're focusing primarily on epi and our amiodarone and our lidocaine for our VF or VT algorithm, focusing primarily on our defibrillations and high quality CPR. For CPR, again, we're going to make sure that we're maintaining that rate from 100 to 120 compressions per minute. And again, we're going to really focus in on early defibrillation. Remember that for defibrillation, you'll be defibrillating at 2 to 4 joules per kilogram. I typically would start out with 2, and then after 2, bump it to 4 and keep it at 4. You could do increase in defibrillation steps if necessary. And then remember, we have to recognize the reversible causes: hypovolemia, hypoxia, hydrogen ions or acidosis, hypoglycemia, hypo or hyperkalemia, hypothermia, cardiac tamponade, tension pneumothorax, ingestion of toxins, thrombosis pulmonary or thrombosis coronary. We really have to make sure we tap into those arrest underlying causes to be able to correct it. Now, neurological emergencies are another component we see on the medical gamut. These include things such as primarily seizures. A seizure is an abnormal discharge of neurons in the brain, and it may be partial or generalized like seizures. The biggest concern that we have with children in seizures is status epilepticus. This is a prolonged seizure or multiple seizures with no true return in consciousness in between. They don't wake up, they remain in a very postictal state before moving directly into another seizure or a continuation of seizures. Now, that's generally pretty common for those who have a history of seizure activity. Oftentimes it could be a new onset that you're responding to. The other more common aspect that you see with seizures is a febrile seizure. This is more common between children between the ages of 6 months and 6 years, and it's typically benign. It's not going to cause any permanent damages to the child or a regular occurrence of seizure activity, but it's still treated as a seizure until it receives that diagnosis. A febrile seizure is generally caused by a rapid rise, or for that matter, a rapid fall in temperature, typically a rapid rise. And in that case, the brain can't handle that rapid rise, and we get a massive discharge of the neurons in the brain, leading to generalized seizure-like activity. Now, your assessment will focus on a lot in regards to history. It's a major factor in determining the type of seizure that's going on. We want to try to figure out how many seizures have happened and how often they're happening during the incident. Any past history that might be helpful, how many of them the seizures have occurred, and what has been done to treat them so far. Oftentimes, parents who know that their child has a history of seizure activity, that they will actually have a rectal Valium administration set to stop those seizures. We want to make sure that the parent gave the correct amount and didn't give too much of that medication, as that can cause a lot of side effects as well. Make sure that you know the medications that they may be on, and then rectal Valium is one of those ones that you'll typically see. The physical exam also should be performed in more of a systematic approach, because really a seizure can be caused by almost anything. There are several risk factors that we also must be aware of when it comes to seizure activity. We're trying to figure out what might be the root cause of the underlying seizure activity or discharge from the neurons of the brain. Things that we can look for that would activate a seizure include things like fever, hypoxia, infections, idiopathic epilepsy for those things of unknown origin, electrolyte disturbances, common with dehydration, head trauma, hypoglycemia, toxic ingestions, or even exposures for that matter, tumors, and then central nervous system malformations as well. Now, for our management, we want to first recognize we're not going to restrain the patient. Oftentimes, parents will want to hold the child in a secure position to help protect them or to stop the seizure. Oftentimes, that will cause more harm, more muscle damage, and the potential where it could even cause small fractures within the bone. We want to protect them from injury, but don't restrain them. It's important to maintain their airway, administering supplemental oxygen, and then establishing an IV. Expect to treat the seizure, right? The rule of Mr. Murphy, Murphy's Law, what will go wrong does go wrong at the worst possible time. So be prepared for that and expect a seizure. Medications you can administer could be Valium or diazepam, Versed, which is more common, midazolam. Ativan is another example that you could use as well. You may want to consider the administration of those medications rectally. Even though we oftentimes think that most of our medications go through IV access or IM or subcutaneously, rectally is also going to allow for a very fast absorption. It does not have a first pass mechanism, so it's not actually filtered out by the liver, and it has a rapid absorption rate. Makes it very easy for you to administer those medications without having to worry about establishing an IV or an IO. If you're going to go ahead and administer medications rectally, you would want to go ahead and use an angiocath. Remove the needle or stylet from the angiocath so you have just a flexible catheter, attach that to your syringe with your medication, and administer that rectally. From there, you're going to want to make sure that the rectum remains closed and that there's no seepage of that medication out. And then remember that oftentimes we may need to consider reversal agents for toxic ingestions, especially if the parent were to administer too much of diazepam from a home rectal seizure kit. Remember, those components are really important when it comes to the reversal agent. Romazicon is what I was trying to remember. Meningitis. Meningitis is an infection of the protection of the protective structures, the meninges. It may be both bacterial and viral. Bacterial infections are typically rapidly fatal, and viral meningitis can self-resolve, believe it or not, on its own within 7 to 10 days. We know that in a normal child, we have the brain, which is covered by the dura mater, and then we have the skull and the spinal cord, all of which are going to be wrapped with that meninge-like structure covering. Now, in advanced bacterial meningitis, you can see that we're going to have infection of the brain tissue. The spinal cord can become infected with bacterial meningitis as well, and the brain and spinal cord both can be massively impacted when it comes to that. Now, there are some assessment techniques that you can utilize when it comes to meningitis. One is Kern sign, and that is where you go ahead and you take the child's leg, bend it up into a 90-degree angle towards their chest, and they'll typically have a significant amount of pain that goes along with that, or when they'll want to try to curve together. The other one is the Babinski sign, and that's where or Brudzinski sign, pardon me, where they flex the child's neck and their knees are going to draw up. Both Kern's and Brudzinski signs are really good examples to utilize when trying to determine if meningitis is present. Again, the Brudzinski sign is neck stiffness causes the hips and knees to flex when the neck is flexed, and the Kern sign is the hamstring stiffness that you would feel, or the inability to straighten the leg when the hip is flexed at 90 degrees. Again, with meningitis, your assessment, we want to look to see if there's any signs of bulging of the fontanelles. That's going to be a major component showing that there's an increase in intracranial pressure swelling due to the infection. You're going to see extreme discomfort with any movement, primarily though with the head or neck. You also will notice a rash that may develop, or a petechiae of some kind where you're going to have bursting of blood vessels, as typical with a lot of viral infections. Management primarily is supportive and then being aggressive when it comes to shock management. Gastrointestinal problems are another major cause of dehydration in the pediatric patient. Remember, dehydration leads to shock, leads to death. Now, with nausea and vomiting, most of the symptoms for other diseases will generally be present. Most common causes include things like a fever, potentially, ear infections, or some type of respiratory-like infection as well. We also have gastroenteritis, which is another example of inflammation, irritation of the GI tract. Both of these types of issues, regardless of nausea or vomiting or both, lead to a risk of severe dehydration and electrolyte imbalance. Treatment for these are primarily going to be supportive with a focus on oxygenation and fluid replacement. We also may want to consider contacting medical control for patients that are younger than 8 years of age to consider if they're having excessive amounts of vomiting, to administer 0.1 milligram per kilogram IV or IM of ondansetron or Zofran. For diarrhea, one of the things that concern us is 10 or more stools per day is considered to be diarrhea. So if they've had 10 bowel movements in one day, that's a lot of liquid to lose. The main concern, again, with diarrhea is dehydration. And again, the treatment is typically supportive, but we're also going to go ahead and be concerned about fluid replacement if and when those become necessary. Now, for metabolic emergencies, diabetes is one of the big ones that we think of. We know that diabetes can occur in very young children. Juvenile onset diabetes, type 1 diabetes being the most prevalent. Diabetic children have great swings in their blood sugar levels. They can be high, they can be low. Both hypo and hypoglycemic patients or events are very possible. Very young children very easily can get hypoglycemia without even having diabetes because they have a very small store of sugar. Their liver, for example, where with an adult we would administer glucagon and that would release those stores of glycogen from the liver, that's not going to be the case in our young children, our pediatrics. Again, they don't have that massive reserve, or any reserve hardly, compared to that of an adult. Now with hypoglycemia, diabetic children increase the risk of hypoglycemia primarily from excessive stimulus exercise. That's one way, right? They're overly active. The other could be is that they're producing too much insulin, or they're having dehydration potentially from an underlying illness. Your assessment really is focused on obtaining a blood glucose reading through your glucometer. Always, always, always check the pediatrics blood glucose level. You're going to say, but I don't want to hurt them. You're going to hurt them more if you don't check a sugar and it's low than if you were to stick them with a Lancet. The other thing that people often ask is, well, where do I check a sugar on a kid? They got really tiny fingers. You're better off to do a heel stick on a young pediatric patient, typically less than a year, and then try more peripheral finger-like access for those that are older than a year. Some of the signs and symptoms that you're going to be able to see for hypoglycemia, for mild sugar levels being low, hunger, weakness, tachypnea, tachycardia, shakiness, yawning, pale skin, and dizziness. That could really be almost anything. Moderate sweating, tremors, irritability, vomiting, mood swings, blurred vision, stomach ache, headache, dizziness, and slurred speech. Again, a little bit more significant symptoms, but again, pretty wide under the gamut. For severe, decreased level of consciousness, seizures, tachycardia, and hypoperfusion. Any of those cases where a patient presents with any of those severe symptoms, we should be immediately checking a blood glucose. It's better to err on the side of caution and obtain that information than not to have it and have the patient end up in cardiac arrest due to hypoglycemia. Management-wise, we're focusing on the airway, breathing, and circulation and obtaining a blood glucose reading. In the conscious and alert patient, we want to try to give some oral fluids with some sugar or oral glucose. Orange juice with a couple big heaping scoopfuls of sugar in there are always going to be a great idea. And then we can also consider things like glucagon or dextrose 25%. We normally deal with dextrose 50%, and that is typically 25 grams and 50 milliliters of fluid. An example of 25% would be something, to be honest with you, we don't really even use hardly anymore because now that I think about it, we're using D10. And the way in which we administer that will be the same because it's preferred to give children D10 than it is for them to get D25. Know that in a 250 ml bag of D10, it is 25 grams of sugar. It just has a lot more volume than you would see in a pre-filled D50 ampule like we had used previously. Hyperglycemia may lead to a lot of components with dehydration and things like diabetic ketoacidosis or DKA. A lot of causes: eating too much food relative to their injected insulin if they are known diabetic, missing an insulin injection, maybe they're on an insulin pump and the pump has become defective, or maybe there's an illness or some type of stress that's going on that's leading to an elevated level of glucose. Big things that you're assessing for, two primary. One is dehydration. Remember, with hyperglycemia, the body's going to try to dump that sugar out through the kidneys and through the urine. That sugar molecule is very large. In order to get it out, it takes a lot of extra fluid to push it out. And so because of that, dehydration is a major concern. Blood sugar readings greater than 200 milligrams per deciliter is, by definition, going to be hyperglycemia. Signs and symptoms: early, not much that you can really tell. Late, weakness, abdominal pain, generalized aches, loss of appetite, nausea, vomiting, signs of dehydration, except increase in urinary output. So they're dehydrated, but they're still dumping lots of urine to get rid of that sugar, remember. Fruity odor to the breath, we're letting so that we're working our way to the ketones, through the process of ketosis for DKA, tachypnea, hyperventilation, and tachycardia. For ketoacidosis, again, continued decreased level of consciousness, progressing into a coma, Kussmaul's respirations, very deep and slow, and then excessive signs of dehydration. Management: remember, the solution to pollution is dilution. So 20 mLs per kilogram, we can increase that, double it down on it once if we need to. If you're not able to give a glucose reading, treat it like hypoglycemia. Hypoglycemia will kill a patient much faster than hyperglycemia. And then make sure that you're gaining that peripheral IV access or IO access. Poisoning and toxic exposures: one of the most common reasons why we see childhood emergencies exist in the pre-hospital setting is from accidental poisonings. We've got to make sure that these homes for children are safely secured and that they're not going to be playing around with all these different chemicals, as you can see in this picture here. The leading cause of preventable death in children is poisoning and toxic exposures. We want to pay close attention to our signs and symptoms, looking for a child who's been exposed to some type of ingested poisoning. We're going to see things like level of responsiveness that may change, including behavioral changes, clumsiness, drowsiness, coma, convulsions, mental disturbances, or even just generalized confusion. We're also going to see the skin and mucosal findings, where we see color and temperature of the skins, lips, and mucosal membranes may be altered depending on the substance, or even burned depending on the substance they've ingested. Temperature, blood pressure, pulse rate, and respiratory rate, you're going to see those all be altered based on, again, the poison or toxic exposure they've had. Pupil changes, both in constriction or dilation, can occur. And then we're going to see a number of components with mouth burns, discoloration, dryness, excessive salivation, stains, characteristics of certain breath odors of a chemical like that was ingested, or pain on swallowing. Nausea, vomiting obviously becomes a major concern, and then diarrhea as well, especially with blood present. Most of the poisoning and toxic exposures you're going to have, you can see drugs or alcohol, most of those are going to be accidental. We're going to try to see where the location of the child is, what substances are near them, and then how can we help, right? Primarily focusing on preventive programs. Poisonings, again, it's the leading cause of preventable death in kids under 5, and that's because they don't have mature body systems. And believe it or not, the worst one that kids often will take is iron supplements, which can really just destroy their liver. Other things you may see is narcotics affecting the respiratory system, cardiovascular medications affecting cardiovascular collapse, hepatic or things affecting the liver, which is mostly acetaminophen or Tylenol, and then GI issues for destruction of aspirin, corrosives, hydrocarbons, all those. Central nervous system disturbances can be caused by narcotics, barbiturates, alcohol, cocaine, anticholinergics, and hydrocarbons as well. So again, a very large gamut of things that they can be exposed to. Management for the responsive patient is to be administer oxygen. Again, be aggressive with your airway management and contact poison control. Remember the number for poison control? 1-800-222-1222. That's 1-800-222-1222. 1-800-222-1222. Poison Control Center. Call it early, call it often, especially with peds. Consider activated charcoal. I know for the state protocol it's no longer recommended, but in the hospital it may be an effective treatment, especially if it's early enough from the onset of ingestion of those pills or tablets. Transport whatever they have vomited or is left, any substances or containers, take those with you to the hospital because they can use that for trace analysis. And then monitor the patient continuously because, again, you may see a decrease rather rapidly or a more slow progression over time depending on what they've taken. Management for the non-responsive patient, again, airway, airway, airway. No airway, no patient. Make sure they've got oxygen. No oxygen, we're going to lead to hypoxia, cardiovascular collapse, and then to arrest. Be prepared to provide artificial ventilations and contact medical control or poison control early. They may be able to help you identify certain antidotes that you can administer. Transport to an appropriate facility and always monitor the patient closely. Now, we have talked about a lot of different medical related emergencies. We focus on the two primary, most critical medical emergencies that we see in pediatric patients, both respiratory and shock related components. Remember that in respiratory, we need to be very diligent about determining the status of our respiratory distress. Is it distress, failure, or apnea? When it comes to shock, we know that we need to recognize the types of shock: distributive, obstructive, hypovolemic, and so on. Those levels of shock are important for us to recognize, as both shock and respiratory are the major concerns we see identified both in research studies that focus heavily on the standards for the pediatric advanced life support criteria and the tools and the expertise you'll need to handle those emergencies when you see them in the field. I hope this lesson was useful for you, and we'll catch you